looking, is navigating the pathway to mental health care in low and middle income countries. So for us to understand pathway to care, we need to do some bit of history. We need to look at the historical development of modern psychiatry practice, how it's come about. So we can basically classify this into three phases. When we say ancient time, which is dated back to like 5th century BC, mental disorders, especially those with psychotic traits, were considered supernatural in origin, caused by demons, and usual treatment were exorcism, physical restraints, music therapy, among others. Numerous examples of this could be found in the Bible. We read about David playing music for Saul when he was in a state of distress. We read about Jesus and his apostles casting evil spirits from people who are disturbed. So this was a belief about a theology of mental illness in ancient period. Then the Middle Age came, and mental disorder was still seen as spiritual disorder or cause that needs spiritual interventions. This evolved into the modern psychiatry practice that we have today, which is about coming into place around 19th, 20th century with advances in science and evidence-based medical practice. So the discovery of chlorpromazine actually changed the whole picture of psychiatric practice. It's the first antipsychotics that were discovered, and the efficacy and everything changed the picture of psychiatric practice and led us into the modern psychiatric practice that we have today. So, but since then, many other antipsychotics have been discovered, and many are still being discovered. I'm trying to move this slide. Not responding. I don't know why. What is the problem? There's some technical issue. I'm going to resolve it. I'll try to exit full screen and see.
Can you send the slide to me so that I can probably be moving it for you?
Okay, yeah. Can I send that through email?
Email, yes, sir.
Okay.
While you continue your presentation.
Okay. What's that? The email?
Window@yahoo.com or Gmail.
Yes, I've done that.
Okay. You can continue with your presentation while I access it, and then we'll get
So I'm still on evolution of psychiatric services in low and middle income country, using Nigeria as an example. The traditional phase whereby we employ, based on the theological explanation of spiritual attack, spiritual basis of a theology, whereby we employ services of Babalawo among the Yorubas of the Southwest Nigeria, for instance, Dibia among the Southeastern Igbo society, and maybe Alpha in the up north. That was the phase that we had before. Then came the transitional phase, that the mixture of the traditional practices and the modern religious practices, a kind of syncretized healing methods. So whereby the churches and the traditional method are mixed together. Then we evolve into therapeutic phase, which I said is the period that was heralded by discovery of chlorpromazine. So we need to define what is pathway to care. And when we are trying to define the pathway to care, this can be defined as a form of help-seeking behavior of a particular group of patients, in this case, patients with mental health problems. It involves decision-making, both on the part of the patient, the relatives and family, organization of care process for a well-defined group of patients during a well-defined period. It is also important that pathway to care include follow-up and recovery phase. There are some emphasis here that is for a group of patients for a well-defined period of time, because pathway to care changes with evolution of culture, with evolution of society. What obtains in one environment might not be what obtains in another environment. And what obtains at a particular point in time may not be what we obtain subsequently after some period of time. So it is important to define which group of patients, which society are we talking about, what period of time are we talking about when we are trying to study pathway to care. So the fact that we should include the follow-up and recovery phase is because many patients are often lost to care too during follow-up period.
Sorry, is the slide showing now?
Yes.
Okay, thank you.
So our discussion of pathway to care will focus on the therapeutic phase. That is, what pathway do patients take? What pathway do relatives take in seeking help for their patients, for their family with mental illness, to get to therapeutic phase? So there are a number of factors that may be influencing pathway to care. So we need to note this factor. This factor may include broadly the patient factor and the service factor. When we talk about the patient factor, when we look at the age of the patient, pathway to care may vary in children, may vary in adolescents and adults. So it may not be the same thing. Because in children, most of the time, the parents make decisions for them as per where should they seek help. The same thing with adolescents. An adult with mental illness, that the judgment is preserved, may be able to take decision about where he wants to seek help about mental illness. But in cases where there is psychosis and the judgment of the adult is impaired, this decision has to be left to the relatives or families to make. So age may be a sort of influence on pathway to care. Gender of the patients. It is important in some society whereby women are not allowed to see male physicians. If male physicians are the only physicians that are available as psychiatrists, the culture does not permit women to see them. Gender could, in one way or the other, influence pathway to care. So cultural background and etiological explanation of the illness. Like we've said before, what do people think is causing mental illness? This play a lot of role in where they seek help. Cultural background is important. Etiological beliefs or explanation about the illness has a great influence on pathway to care. So patients, relatives, and friends. They are usually the caregivers in low and middle income countries, and they have a lot of influence in determining the pathway to care. So when we still talking about patient factor, we can look at place of abode or the location of the patient. Is he a rural environment? Is he an urban community? Or is he a rural urban community? This has a lot of role in influencing pathway to care. How far or how close is the services to this place of abode? Is there proximity to services to the patients? That's very important. Level of education of the patient and caregiver. This has a great influence too on determining pathway to care. A highly educated person that is very exposed is more likely to take appropriate decision about help seeking and approach the orthodox practitioner compared to somebody that is illiterate and do not have any background form of education. Prior experience is very important. What experience has the person have about seeing other people with mental illness, about seeing other people have intervention for their mental illness? This plays a significant role too. So when we look at symptoms that the patient presents with, severity or tolerability of patient's illness symptoms by the family. For instance, if a patient is depressed and he just keeps to himself, do his things gently, such a patient might not seek help on time because it's not a disturbance to the family. But if a patient is frankly psychotic, disruptive, and is of danger to the family, for instance, they are likely to quickly seek help. All these factors about tolerability of symptoms of the illness influence pathway to care. This list that I've made is by no means exhaustive. So pathway to care have a number of factors that influence it. So when we look at service factors, we need to ask the question, is the services available at all? How close is the services to the location of the patients? We need to ask the question about cost and affordability of the services. Out-of-pocket payments or presence of community or national insurance have a great influence on pathway to care. Proximity of services, like I've mentioned before, and service satisfaction. How satisfied are the patients and the relatives about the services that they received from service centers? Service satisfaction is important. So this is just an example of pathway to care stages. First point of contact, where the patient goes first. We look at point or source of referral before they now get back to orthodox care, where they may be lost to follow up after they have taken first level of care. They either go to recovery or go to relapse or recurrent state. So I try to highlight some examples of documentation in literatures about pathway to care. In a study by Gureji et al. In 1995 and Abiodun in Ilorin in 1995 too, found that a sizable number of their patients in southwestern Nigeria and in north-central Nigeria, respectively, visited traditional healer and faith healer at some point during the course of their illness. So all these visits to the traditional healers are belief of our people about a theology of mental illness. They think most time that is due to spiritual causes. So, and they think help is best sought from traditional healer compared to orthodox practice. So I try to look at issue of losing of patient to follow up. In for a time in 2019 documented that about 26% of patients admitted for schizophrenia in a psychiatric hospital in southeastern Nigeria were lost to follow up immediately after the first clinic appointment. There are a number of factors that may be responsible for this, as I've highlighted before. The proximity of the services, the cost of the services, a number of factors that may make patients get lost to follow up, and it may be the belief of the patient about the etiology of the mental illness too. So children may experience different pathways to care because of their choice of help-seeking behavior. Because the choice of their help-seeking behavior is likely influenced by their parents or caregivers. This according to our own study in 2013. So when we look at criminal justice system and pathway to care, we will notice that patients with mental health problems or those with psychoactive substance use often have impaired judgments. So in fear of their impaired judgments, they are prone to committing crimes that might lead to arrest by law enforcement agencies, such as police or drug law enforcement agents. So the police or drug law enforcement agents may bring them in contact with mental health services. Law enforcement agents also contribute to pathway to care through referral of cases. So we should take note of that, it's very important. So when we look at consultation like in psychiatry, for instance, and pathway to care, we notice that mental illness often occur comorbidly with other physical illness. And patients may seek help for these physical illnesses first, before the practicing physician notice that this patient might be having comorbid mental illness. And it now rests with the general practitioner or the physician to refer the patient or treat the patient at that level. So for instance, obstetric and gynecology care, a patient may have postpartum depression, may have postpartum psychosis, and may have pseudopsoriasis. Such a patient needs to be referred for psychiatric care. And oftentimes they will be seen first by one G specialist or a general practitioner. Chronic medical illness, acute medical illness, they occur comorbidly with depression all the time. So it's in the purview of physicians or general practitioners to refer such patients or to assess such patients first and make the diagnosis and then give appropriate referral if there is need for it. So general hospitals, general practitioner may be a first point of contact for patients with mental illness, and availability of mental health services in general hospital with general practitioner practice, it needs to be considered, and it's important. So we look at human rights and mental health services. Most human rights laws in different countries provide for the right of every citizen to mental health services. So to achieve the objective of reaching the largest number of people with mental health services, community or public mental health services that suit a particular situation need to be designed. What do I mean by this? We study pathway to care in relative to a certain population of people in certain to sociocultural environments. We need to understand the psychology behind behavior of people. Why do they make such choices as they make? So for us to now design services for them, we need background information about their pathway to care. So, and it's their right for us to get mental health services to them to reach the largest number of people as much as possible. So studying pathway to care helps us to know the kind of services we can design for a particular group of people based on the psychology of their behavior, psychology of their help-seeking behavior. So that is the reason why we study pathway to care. We study pathway to care in a particular group of people at a particular time because we need background information to develop various models of community psychiatry services that will fit a particular community and improve access to services. So the objective of this service design is to incorporate all the pathway to care identified into community psychiatry services that is being designed for a particular community or for a country or for a specific low and middle income country. So I try to look at issue of community psychiatric services in Nigeria. We know that in 1990s, the Federal Ministry of Health, Abuja, incorporated mental health as the 9th component of primary health care. Although this has been on paper, it has not actually been implemented to a greater success, as we all know, throughout the country. Some significant policy paper has been made, but implementation has been a problem. So the model of community mental health services recommended for Nigeria include enhancements and linkages, according to Muideen in 2001. Enhancement means that training of community mental health care workers about basic mental health symptoms, treatments, and referral. This process has made use of MH gap developed by WHO in various communities in low and middle income countries. And when we talk about enhancement, it is not only community health workers that we can train. If you study pathway to care and we realize that many patients are going towards traditional healers, are going towards Babalawo more, or they are going to syncretic churches more, we can always train those pastors, those imams, those traditional healers too, on basic recognition of mental illness and work with them on process of referral. This is also important in the process of enhancement. So linkages. Linkages mean that mental health professionals leave their tertiary or secondary care to consult patients alongside primary health care workers at primary health care level. This also means that if we are working with traditional healer, for instance, we can pay a visit to them, look at the patient they are seeing, and make contributions to the services they provide, and do consultation with them. Depending on which pathway to care, depending on individuals we are working with, it's our background study of the pathway to care in a particular environment that will determine the direction our enhancements or linkages will go. It is important we note this. So, designing community mental health care for adults using identified pathway to care. We need to get cooperation of traditional and faith-based healers, for example, to work together with orthodox medical practitioners through the process of enhancements, like I've said, linkages, like I've mentioned before, and using a combination of enhancement and linkages methods is been noted to be the best approach to adopt in low and middle income countries. So we use both a combination of enhancements and linkages in providing services. Enhancement, working together with traditional healers, working together with faith-based healers, working together with community healthcare workers. We use this process of enhancement and linkages, a mixed method, to achieve the best outcome. So when we talk about children and adolescents, for instance, we want to design community mental health care for children and adolescents. and we identify the pathway to care. We cannot but talk about school-based mental health programs. We know most children are in school, and this will involve training, enhancement of teachers about mental illness, recognition of mental illness, and also linkages such as school consultation, having a psychiatric nurse visiting the school, having a developmental psychologist in the school. Those kind of processes are very important in designing community health care for children and adolescents. So we look at primary health care clinic, which is important because a lot of children visit primary health care clinic because of febrile illness. And as a result of febrile illness, there are a lot of neurodevelopmental conditions that surfaces as complication of febrile illness. So for instance, there may be seizure issue accompanying febrile illness. There may be cerebral malaria issue, meningitis issue. They lead to many neurodevelopmental disorders in children. So working together with primary health care clinic or the general hospital for child and adolescents community psychiatry services is very important, because most often times they present with physical problem first, which now have attendant comorbid mental health problem. So we should work with places of religious worship too. It may provide avenue for advocacy, enhancement for key people about common child and adolescent mental health issues. Roadside laboratories and patient medicine stores. In our study, we found that many parents take their children to roadside laboratories when they are febrile, and they consult the roadside laboratory first before they present in psychiatric hospital because of complication of the febrile illness. Many of them visit patient medicine stores and buy drugs before they are referred to psychiatric hospital. So all this level of care or pathway to care needs to be incorporated in designing community mental health care for children and adolescents using the identified pathway to care, depending on the population, depending on the period of time that we are talking about. Is everybody hearing me?
You are on, we are hearing you, please.
Okay. So I try to highlight the only community psychiatry service in Nigeria, the one that we have as a template that we have run before and it's been successful to a large extent. In Nigeria, the system of community psychiatry, and it's called in the treatment of mentally ill persons. Most community psychiatry service design should be predicated on pathway to care findings in such a community at a particular time period. This formed the basis for our village system, where it was started in 1954. The method of community psychiatry service leverage on family support system. It involves actively the family and relatives in management of the patient. This method had the advantage of changing etiological beliefs or perception about mental illness. Why do I say this? Because the relatives are actively involved in the management, and they were able to see progress of their patients, and they were able to see the prognosis during the treatment. And they are eyewitness to the wonder of modern medicine. They are eyewitness to therapeutic phase of mental illness treatment. They see how their relative recovers. So when they see this, it changes their belief or perception about the etiology of mental illness. And when this changes, it goes a long way to reduce passive stigma. About mental illness, and promotes appropriate help seeking. Recommend to others and say, no problem, I think you should go to this hospital because this is where the problem was resolved for us. So that background experience is very important. So I think essentially that is all about pathway to care. And these are a list of my references for further readings. I will entertain questions and answers. Thank you very much.